Okay. Would you like to share the screen and I will make a small introduction?
Yes. Just I want to say to George, he's totally right. We clocks on the shortage of electricity. Okay. Internet connections unstable.
We can see the screen.
Okay, Sarah, you can start.
Okay. First, we would like to thank you all for attending the webinar organized by the Lebanese manufacturing company Algorithm in collaboration with the Lebanese Society of Obstetrics and Gynecology. And we would like to welcome the speaker of this session, Dr. Finan, FACS, Associate Professor at St. Joseph University, President-elect of the Lebanese Society of Obstetrics and Gynecology, and Vice President of Fédération Francophone des Sociétés Obstétriques et Gynécologiques. Please, for your questions, kindly put them in the Q&A section, and Dr. Finan will answer them at the end of the webinar. Gentle request if you can answer as well 5 questions survey as webinar evaluation. I will leave the floor now to Dr. Thank you.
Thank you. Good evening, everybody. We're going to talk about a subject that is not new to all of us. This is the bread and butter for all of us. Vaginitis are a wide spectrum of condition, vaginal or vulvar, mostly itching, burning, irritation. Most complaints are the itching, the irritation, the burning, the pain, the soreness, and they represent 1/3 of our consultation, mostly related to vulvovaginal candidosis or bacterial vaginosis or trichomonias. These are the most common and the one we know the best. We don't talk a lot of the sexual behavior causes, which I will talk a little about later on. In the etiology of vaginitis, the candida is something between 20 and 40%. The BV is 20 to 50, and the trichomoniasis is around 35%. 30% of the women that are coming to our clinics remain undiagnosed even after the clinical evaluation, and we will see why later on. Even if we do the pH level and the microscopy results, individual symptoms and signs are not always leading us to a diagnosis. That's why one-shot therapy with a broad spectrum might be more interesting when we don't know. Some tips for the differential diagnosis before going into the real stuff. If you don't have itching, candida is likely not the cause. If you don't smell a fish odor, bacterial vaginosis is unlikely, and most probably it is a VVC. Inflammatory signs are more in favor of a VVC, and the fishy odor is usually BV or trichomonas. This summarizes almost everything. You can see that the bacterial vaginosis, mostly due to the Gardnerella and Mycoplasma, gives the fishy odor. And we will see that when we put the KOH on the secretions, we do smell the amine fishy odor. But there is no pain, no pruritus, no clinical signs, and usually the woman doesn't even know that she has any infection. But sometimes she might be annoyed by some secretion, white, gray, mostly. The trichomoniasis due to Trichomonas vaginalis will give a frothy discharge, green, yellow, on les appelées spumeuses. There is a lot of pain with the sexual intercourse, vaginal soreness, and dysuria. Typically, it's the strawberry cervix. The candida, all kind of candida, albicans, cruzeae, glabrata, will give the white, thick discharge, no other, burning, dysuria, dyspareunia, and sometimes ulcers on the vulva. The itching is very frequent. This is typical of the candida and for the erosive lichen planus. Then we leave the bacteria and we come to the atrophy. After menopause, if there is no HRT and she's not taking any local cream, we can have estrogen deficiency, and it can give us a yellow greenish, no odor at all, but the vaginal dryness, and mostly during intercourse, the pain becomes unbearable. Sometimes the vagina is mildly erythematous and traumatized very easily. She might bleed when we are doing the checkup just due to the lack of estrogen, no elasticity in the tissue. The erosive lichen planus, we don't know the etiology, and the pain is severe, and the itching is severe, but it's much less frequent than the rest. We can have irritant allergic contact dermatitis. Usually it's due to allergic reaction to any product. Gives a lot of burning, and the vulvar erythema is very possible, and this does not include in all the types of these signs the vaginismus, the burning after intercourse when we don't have a relaxation, when we don't have the wetness in the vagina, and this is one of the most frequent but not easily said cause of the newlywed without experience before. This is the only slide on the pregnant woman. I just added to show that if we just do a vaginal swab of betadine or the chlorhexidine, we can lower the mortality morbidity of the C-section by a simple cleaning after putting the Foley catheter. It might help a lot. The vaginitis in the non-pregnant woman is the most frequent reason to visit the gynae. Most common vaginal condition in the 15-44 years in the States, 30%. Most women, or 84%, will not report any sign. Women who have not had sex can still be affected in like 19%. We'll see in other texts, they say if you don't have sex, you will not have BV, which is not really true. In pregnancy, we have 25% of infected women. And we'll see later on that the BV during pregnancy can lead to some problem. A woman who had been pregnant before has a higher risk of 31. And the BV is linked to the number of sexual partners, even if until now we say the male partner is not the cause. But I will show you a study done on the unfortunate date of the 4th of August 2020, where they are linking the bacteria of the penis and the meatus and the sulcus with the BVs of the females. In the States, the a higher rate, 51 for the Afro-Americans, 32 for the Americans compared to the 23%, maybe linked to the lower economical class. What are the risk factors for vaginitis? Low socioeconomic. The vaginal douche is not recommended by the ACOG. I usually use it once when I have a severe infection before starting the treatment, but certainly not regularly. The IUD and the unprotected sex are BV and trichomonas. Spermicide sometimes leads to ABV. Drug use, smoking, new and multiple partners. They are all for BV mostly, and trichomonas, some of them. The only risk factor for the candida is diabetes, refined sugar intake, and vaginal or oral antibiotics. Some facts. As I said before, rarely affects people who have never had sex. In fact, we can have it in some studies up to 18%. More than 50% asymptomatic. We just saw 84%. It occurs in sexual active. The BV is linked to an imbalance between the good and the bad bacteria. The lactobacillus, the normal bacteria of the vagina, which gives the acidic taste, is the normal bacteria that is supposed to be profused in the vagina. We call it the daughter line, and she will protect from the bacteria coming from the bladder or from the anus and rectum. So whenever we have a disbalance or a lack of normal hydrogen peroxide producing lactobacilli, there will be an overgrowth of anaerobic bacteria, and this will lead to the vaginitis. A new sex partner or multiple sex partners can be linked also. And we said about the douching. Know how sex contributes to BV. No research to show that treating a sex partner affects whether or not the woman to get a BV. So it's not a sexual transmitted disease, but the male sex partners of the woman diagnosed with BV, generally, we don't treat them. Sometimes when we have a lot of recurrence, we do it without being really convinced about doing it. The BV may be transferred between female sex partners. You cannot get a BV from the toilets, bedding, or swimming pool. An increased chance of getting other STDs by doing an inflammatory reaction inside the vagina. The reinfected patients, can it be just by the exposure to an untreated partner? Or is it the flora that is not correct? And the reinfection and the BVs are high, around 17%. During pregnancy, the problem is that it might give late miscarriages, premature rupture of the membrane, and preterm birth. That's why if the woman is annoyed, a vaginal culture might help if we don't see anything wrong. In the past, we used to diagnose the BV by the presence of 3 out of 4 of the Amsel's criteria. The thin vaginal discharge, the pH more than 4.5, the whiff test that we talked about, the fishy amine odor when we add the KOH solution on the vaginal discharge, and the clue cells that we see sometimes on our pap smear reports. The clue cell is when you have the epithelial cells bordered with the cocobacilli that gives this kind of thick border. The study that I'm talking about is the Mehta study. He's an epidemiologist from Illinois, Chicago, USA, and Stephen Green from Kenya. They enrolled Kenyan males from 18 to 35 and all the females that were above 16 years. They cultured the meatus and the sulcus glands coronal by swab, and they amplified the V3, V4. The aim of the study was to predict the relation with the BV in partners. The results were the cumulative incidence of BV was 31.6% in 168 couples studied. The point is, when they started the study, none of these women had a BV at baseline. They noticed that 27% of the women had a circumcised male partner versus 37.3% if the male was not circumcised. About the 52 women with the BV, 36 had one episode of BV, 13 had two, and 3 had 3 episodes. Statistics of the males, 56% of them were circumcised. The men reported more sexual partners, 21% than one, while only 3% of the women said that they had outside partners. The condom use during the last sexual activity was infrequent. More than 17% reported having a condom. So what they found in the cultures they have done on the meatus mostly were the bacteria like the Parvimonas, Lactobacillus iners, and Lactobacillus crispus, and the Gardnerella vaginalis, that were the most identical with the BV's culture done in the woman. And then when they compared the accuracy of the gland culture and the sulcus culture, the sensitivity was 80%, the accuracy 77%, and showed that it was very comparable to the meatal culture. So the makeup of the bacteria that are colonizing the man's penis can predict sometimes a serious and hard to treat vaginal infection in the female partner. And the woman who had a partner with bacteria were more developing the BV within the year that follows. In Kenya, the BV frequency is 20 to 50, like almost everywhere in the world, but the recurrence of the BV was 50%. So as a conclusion, the increased risk for the woman if she takes antibiotics, vaginal douching, or circumcision, and non-circumcised partners, we already said that. But we couldn't get a final result if we treat the partner, if it will help the recurrence, neither by oral antibiotics for the male, nor local topical cream on the penis. And they tried the metronidazole 400 milligrams twice daily, or once 2 grams, and the 2% clindamycin cream topical for 7 days. Nothing showed any difference. So it's still unclear if V is caused by the male microbiota or due to modification of the females when contaminated by the other bacteria. Four main findings for the study. Penile microbiome can predict the female incident of BV. It's the same meatus or sulcus or the sillon prépucio-balanique, as we call it in French. A lot of meatal bacteria are overlapping with the vaginal bacteria that we found in the woman. And the circumcision seems to have a low variable importance in the prediction because it didn't show any statistics that will say a clear cut in this issue. Let's talk a little about the candida. The frequency of the crisis is usually once in a lifetime, 75% of the female. Twice or more is 40 to 55%. We talked about the changes in the host's vaginal just few minutes before about the good lactobacillus, the daughter line, and the overgrowth of the anaerobic bacteria. The signs of the candida are the pruritus, vaginal soreness, dyspareunia, and vaginal discharge. Normal vaginal pH is 4.5. The whiff test is useless and negative in the candida. If it's a recurrent infection, a vaginal culture might be useful, especially if she's not responding to a classical treatment before passing to the guidelines where we have to treat for 6 months weekly. And the pap smear is specific but insensitive. In 100 women positive by culture for candida, only 25% were found on the pap smear. The NICE guidelines recommendation for an uncomplicated vulvovaginal candidiasis, intravaginal antifungal cream or pessary, clotrimazole, iconazole, miconazole, fenticonazole, all the azoles are working perfectly. Oral antifungal, fluconazole, itraconazole. If she's not cured, or if she has recurrent more than 4 times a year, the guidelines are 150 milligrams of fluconazole every 72 for 3 doses as an induction, and then once weekly for 6 months. Are you following these guidelines? I'm not, to be serious, I'm not doing a treatment of 6 months weekly before trying sometimes multiple regimen or changing the ovules or the oral antifungal. The treatment for VVC, BV, and Trichomonas, where we have 2 stars, it's when you can give the treatment as a one-shot treatment. Fenticonazole, if you use the 1000, not the 600, works on the VVC, BV, and Trichomonas. The Canesten works on the VVC only. The cyclopyroxalamine works on the VVC. They say it works on the BV, but was not confirmed by any scientific paper. Flagyl works on BV and Trichomonas. Orally, some use vaginal metronidazole, but it doesn't work at all on the bacteria on the candida. The secnodazole also works on BV and Trichomonas. Fluconazole and itraconazole works only on the candida. If we want to compare between the products, the study was done by the fenticonazole group versus miconazole, iconazole. The culture were done to check on the Candida albicans. I put the commercial name to know the brand we are using. Fenticonazole is the Lomexin, miconazole is the Monista, and also present in the Ovumix in a combination. Iconazole is the Pevaril and part of the Pevizone cream. If we compare the minimal inhibitory concentration needed to get a result, we can see clearly that the Lomexin has only 8, while the other needs the double of the concentration for the miconazole and iconazole. We can see also that the fenticonazole, as we said before, works for BV, Trichomonas, Candida, and it works also on the Gardnerella, as we said, on the Staph aureus and on the E. coli, which makes it a very wide spectrum. The efficacy is also higher after 7 days. Compared to clotrimazole, it's almost the same, 88.5, 92, you will say there is no big difference. But when you go 1 month later, the difference starts to be much more evident. The clotrimazole is the canesten, which I don't know if it still exists, but the 500 disappeared from the market lately. It's a rapid and long-lasting effect on the pruritus, on the burning sensation. After 2 days, we are almost free of them. Even if we do have, when we put the vaginal ovule to an old product, sometimes a sensation of severe burning. The cure rate is 92%, and a single intravaginal ovule is sufficient for that. The minimal systematic absorption, 5 days after one vaginal tablet only, we still have it in the vagina, in the vaginal washing, almost nothing in the urine or in the feces, which means it's a local, no problem. The low rate of recurrence of vaginal infection, the study was done with the 600, not the 1000. 4 weeks after, recurrence rate was 6%. And that's one of the reasons why, when they did the cultures, they showed that there was a combination of Candida and Trichomonas, Candida, Trichomonas, and other Trichomonas, not Candida, even if the doctors thought it was Candida. Trichomonas and other, since fluconazole works on them, the recurrence becomes much less. The take-home message: vaginitis is your bread and butter. You can miss the diagnosis. 30% of your patients are going to come for vaginitis. If you miss the diagnosis, you can lose the patient. But unfortunately, our patients, when they leave, they go with the family and friends. It's all a group that you might lose. The compliance is related to the length of the treatment and the number of drugs prescribed. The less they are, the higher is the rate of compliance. The one-shot therapy helps to cure the patient and to get the culture results if it's done before adjusting the treatment. We talked about the sexual behavior and the irritation of the vagina, which can lead after intercourse to burning sensation, to irritation, especially in the vaginismus, especially in case of contractions, not allowing the partner to go inside. Beware of this as a pitfall. We all lose patients because of that, because if she's not relaxed, if you don't examine her, if you don't see that she's contracting, you might treat her as we do over the phone without telling her to use simple oil to get an easier intromission. And this can help a lot. Thank you for your attention. I will stop sharing and check your questions. Sarah, the floor is yours. Anthony is asking, what is the protocol in the chronic and recurrent vaginal candidiasis? The protocol, the guidelines say that we use a oral antifungal 150 milligram fluconazole and 3 times, and then weekly for 6 months. What I usually do, I do use the beginning of the protocol, the 150 milligrams every 3 days for 3 times. And then I use vaginal and oral after the menstrual cycle for the next 4 months. Because usually the media of culture for the candida and other pathogens is the menstrual flu. Once the menstrual flow, sorry. Once the blood is in the vagina, the bacteria start to take again the control over the lactobacillus. So if at the end of every menstrual cycle, for a period of 4 months, I give an oral fluconazole or and a vaginal tablet, I usually prevent the development of the pathogens and help the lactobacillus to grow. I don't know a lot of people who were willing to go for 6 months weekly on fluconazole. I don't know, it's my experience. I would like to share with the audience if somebody had another way of treating the chronic and recurrent vaginal candidiasis, or do you give weekly for 6 months? They are silenced all.
Yes, nobody is raising his hand. Dr. Lara Haidar. Do you give
lactobacillus ovules or PO to prevent recurrence after one episode? After one episode, maybe not. In recurrent infections, yes, I do give. We have the Genoflor in Lebanon, we have the Relactagel, and we used to have the Lactogene, but it's out of the market. I do give probiotics orally. It seems that if you control the lactobacillus in the colon, it might help, and the transmission from the colon to the vagina does help. But practically there is no harm in giving lactobacillus. This is the treatment, because once you have lactobacillus inside the vagina, you don't need to treat anymore because they will take care of the pathogens. For chronic patients, Salah, what was the question? Another one of what we answered now. Dina Rumiye, hi. Per os after 4 or 5 episodes? Yes, but one single Lomexin 1000 at the end of the menstrual cycle, while they are still having some blood, will not harm, and they will not get annoyed if you tell them that having 4 or 5 episodes per year means chronic candidiasis, which means that one tablet orally, one vaginal ovule should be something for 4 months. During the period, she's not going to have any activity. And if she put it in the last 2 days of her menstrual cycle, she will not even stop activities afterwards. I do suggest strongly to use this instead of the oral weekly for 6 months. Does anybody give 6 months of weekly fluconazole?
Dr. Aitana wrote in the chat. Yes, sometimes we used to give a maintenance treatment for 6 months in case of repetitive and recurrent vulvovaginal candidiasis.
These are the guidelines. I know, but the question is, are the patient going to go on with this? They must be really annoyed by the VVC to go for 6 months weekly. And the problem, most of them, when we finish the 6 months, they will relapse because most probably the origin is somewhere else. I haven't done it any time. I haven't done a prescription of 6 months weekly. Saad have more experience maybe in that, but the number of patients going on taking the drugs, I think, is very low. Maroon Rad is writing, a very old protocol talks about fluconazole 150 milligram, just 1 week before the menstrual for a period of 6 months. It's almost the same. I give it after the menstrual cycle because I think the blood is the culture media. If you take it before the menstrual cycle, it's exactly the same. You are filling the body, and the culture media will not let it grow. And this might be done. I think that the issue is taking it once monthly. Once monthly is much easier to pass.
Dr. Lara Haidar coming.
Read it because I'm not being able to read it.
Dr. Lara Haidar, she said that no, she starts 3 months and then بترجع بتجدد. So usually for 3 months.
Okay. The important thing is to let the patient keep faith in you, not let him feel that you're not knowing what you're doing. You can start by telling them that the treatment is supposed to be for 6 months weekly, but we can try the other protocols before starting this long treatment to avoid taking a lot of drugs for a long period. That's what I usually do. And I shift to the 1 tablet after the menstrual cycle. We can give it 1 week before, doesn't mind. 1 vaginal ovule at the end of the menstrual cycle also. Any combination that helps. And even if she has to take it 3 to 6 months and then recur after 6 months, she can redo. The treatment is easy when it's just once a month. That's my opinion.
Dr. Salah, how often do you screen for HIV or diabetes in case of Candida?
HIV I don't usually do unless I have a clinical suspicion, but I usually do it during pregnancy and before marriage, or if she tells me that she has a lot of partners or her husband had a lot of partners. For diabetes, I do it regularly in every blood exam. A fasting blood sugar will do. Sometimes we do the HbA1c, but practically a glucose level, fasting glucose level is sufficient. And I check for pollakiuria, nicturia, and polydipsy, but usually we can detect it much easier. But if you suspect, no problem doing it, and to explain to the patient that this might be due to this side effect.
Okay. Also, he asked regarding chronic Candida, how often do you screen for HIV or diabetes in case of chronic?
I screen for diabetes. I should, but I didn't screen for HIV. The prevalence of HIV in Lebanon is low, so I didn't think about doing it when I have a regular chronic Candida. My fault. I think I will start doing it now.
Okay. Anonymous attendee, some patients report pruritus after the menses only or a few days before and are disturbed from it. Does it count as diagnosis?
It does mean that she has something that is increasing when the blood flow in the pelvis increases before menstrual cycle and during the cycle at the end. If there is any clinical sign, sometimes it is interesting to do a vaginal culture to check if we do have other pathogens in the vagina.
Okay. Also, Dr. Salah asked for the 6 months therapy. Should we screen before for HIV?
Yes, it's better to do so. If she's going to take this treatment for 6 months and a week, weekly, we better do a screening to avoid missing something.
Okay. Dr. Dina, that all patients that took 6 months relapsed at
I
the
don't
end,
hear
and the
you,
compliance
Sarah.
is. Can you? now?
We have problems hearing you.
Can you hear me now?
Yes.
Okay. So Dr. Dina Rumiya
mentioned, I didn't hear anything after that.
6 months. Okay, maybe it's my connection. Now it's better?
Yes.
Okay, Dina Rumiya mentioned that all patients that took 6 months relapse at the end, and the compliance is, it seems that it wasn't a good compliance.
I do agree totally with her. That's why I do the one-shot monthly regimen and try to avoid this weekly 6 months treatment.
Okay, Dr. What sensation inside the vagina without any vaginal pathology?
I don't hear you. Sorry, Sarah.
I don't know what's. Yes, I don't know what's. And now, can you hear me?
Yes.
The vagina, evidence of any vaginal infection and or pathology. What about the role of hyaluronic acid in this issue as regenerative medication, and it's used in addition to antifungal therapy?
Usually when you use the hyaluronic acid, it rebuilds the mucosa of the vagina and helps the lactobacillus to take over again. And we do have these kind of vaginal tablets in Lebanon, and we use them after the treatment, after cleaning the vagina, after giving her back the lactobacillus. And in case we don't have a normal vagina, I use them just to restore, especially in menopaused women.
Okay. Dr. Lama Darwish, should we request liver enzyme test before 6 months treatment with fluconazole?
Certainly, because if ever the patient had a problem in the liver later on, you will be accused of having harmed her. You always should do, before starting a 6 months regimen weekly, you should do a complete workup. I will add the HIV now. I didn't choose to do so, but we should always do a full blood work to be sure that we will not be accused later on of giving a drug that made a hepatic lesion, and you will be blamed for that.
Okay, Dr. Modi Farhat mentioned post-menses it's better. I don't know exactly.
Yeah, because we were talking with Dr. Marwan Raad about giving the tablet before or after the menstrual cycle. I said on both sides it works, but after the menstrual cycle, it's a question of habit mostly, I think, much more than a differential regimen.
Okay. Dr. Salah also, he asked, is there a role for gentian violet in treatment of candida?
It's an American way of treating. I have never used it. I don't have any experience in it. Anybody on the floor knows about it?
Still there is no answer yet.
Saad, any clue or Michelle on the gentian violet?
No answer yet.
Did you, Salah, use the gentian violet? And can you find it in Lebanon?
Sorry?
Did you use it?
I heard Somebody is using it here in Lebanon, and it was doing fine. But I don't, on my patients themselves, I know I didn't use it, but I heard that somebody was using it and it had a good result. Yet it causes a lot of dryness in the vagina.
Yeah, that's what I read, but I didn't use it. I never had the opportunity to use it. It's not in our protocols. I don't know if we have it in Lebanon.
Yes.
Dr. Saad Eddin Aitani also wrote, he said no in GV. Oh. Dr. Wajiha Jaber. Dr. Wajiha Jaber, you are unmuted. If you have a question.
No, are you hearing me?
Yes, we can hear you, yes.
Okay, hi, Dr. Ramzi, how are you? Fine?
Fine. How are you?
Fine, thank you for the presentation. I am with you. The protocol that not to give it more than 3 months to 6 months, it's too much. And I agree with you 100%. Only that I want to say. Thank you.
Well, the nice guidelines from the beginning were a bit too aggressive, but these are the guidelines.
Yeah.
But we can modify them accordingly to the patient and to keep the patient's compliance.
Yes,
I
of
have
course.
never seen the patient taking for 6 months.
Yes, yes, I am with you. Okay, thank you.
Thank you.
Thank you.
Dr. Rami Asi mentioned that gentian violet is banned in some countries. Now there are till now there are no other questions. I don't know if anyone still has a question. Thank you so much, Dr. Finan.
Thanks to you all. Thank you for being an excellent audience, and hope all is good and we keep safe, inshallah.
Thank you all. Thank you, Dr. Finan.
Thank you.
If you can fill the evaluation form just to assess the webinar. Thank you so much for your attendance.
Thank you, Dr. Finan. Thank you, doctors, for your presence and attendance.
Thank you, everybody.